we're very keen to look at Crohn's disease, for example. We know that if you take a patient with Crohn's disease and you replace their bacteria with normal fecal, it's called an FMT, fecal microbiome transplant, a number of those patients will do very well.
Let's just take a look at that, Robert, actually, if you don't mind. Is this the slide here?
Yeah, this one. Oh, here we are. Yeah, this is not my slide. I stole it. But you can see this is what FMT is about. It's been popularised. It was really developed by Tom Borody, who I had the pleasure of having as a PhD student. Tom is
who I met last April. Great guy.
Yeah, that's right. He's the guy who discovered the treatment for peptic ulcer, but wasn't on the Nobel Prize list. Tom's a very, very smart guy. And he developed this back in the 60s and 70s, and now has taken it to another level. And what it is, it's screening normal, healthy people and taking their feces and concentrating the bugs from that, and then infusing it through a colonoscope, which is a tube that you put up through the bottom and goes up into the colon. You can see, and everyone laughed at Tom when he started doing this, but he plugged away, literally plugged away, I suppose is one way of calling it, and then a group in Holland said, well, we'll do a randomised controlled trial in a particular disease that was doing so well with FMT called C. difficile. He started treating these patients before it was even called C. difficile. And the Dutch published in the New England Journal of Medicine, it must be a very good journal, and the New England Journal published this paper, and the study wasn't finished because the outcome was so dramatic in the active compared with the placebo. They stopped the study and started treating all the placebos with the fecal microbiome transplant. And there was a 95% cure. Now, this is a condition that in America today, there's something like, I think it's 10,000 cases a year with it's more than that. There are 3,000 deaths a year from this condition. And you can get a 95% cure. And around the world now, everyone's talking about it, and they're all trying to, develop systems to treat. But there's a lot of, this is just the beginning. It's going to really go into a much more sophisticated form. Now, they're doing with FMTs, with the microbiome, what we're doing with the immune system. So what I'm saying is we need to bring these, think of it as a simple single system, and let's treat with both making the immune system work better and putting in better bacteria. And that's what we want to do in Crohn's disease, because we know that if you change the microbiome and get away from from a bad microbiome to a good microbiome, many of these people will do very well. And there are now 3 randomised controlled trials in ulcerative colitis showing significant benefit. So we're just at the beginning of this type of treatment.
But there's no sophisticated clever clogs drugs here, Robert, is there?
That's the problem.
Isn't this a bit of a concern? Shouldn't we be trying to be really clever and need the sophisticated pharmaceutical companies to do clever things for us?
That's what's going to happen. The big pharma companies will do that because that's where they make their money. There won't be better treatments. Well, they might be. Let's hope they are. But they'll be much more sophisticated. They'll be cloned antigens. They'll be specific. They'll work out what antigens are going to work best. They'll delivery systems will improve. All the usual things.
I mean, I could do this in any hospital ward. I could take some poo, dilute it in some water or saline or whatever the recipe is, and just run it in like a mini enema. It's a very simple thing. No drugs involved whatsoever.
That's exactly. Oh, well, we usually clear out the. We wash the. Well, you just wash the colon out, get rid of all the bugs that are there, and put the new ones in. It's as simple as that. That's what we're doing here.
And you and I have both seen patients' lives treated by Professor Tom Borody transformed by this.
Yeah, that's right. You came along to one of our clinics.
I met them, and I was just, there was a patient who was going to get a total colectomy in England, taking out the whole colon. That's right. And basically, Tom Borody basically cured him by cleaning out his colon and putting in a few new bacteria. It was startling.
Well, look, my introduction to this particular bug was when I was working as a junior professor at McMaster University in Canada, and all the interns went on strike. Gee, that was a long time ago, and so we all had to double up, and I had to go and help the surgeons operate, and we had to do an emergency colectomy on a patient with exactly this same C. difficile infection.
And other causes of things like, ulcerative colitis and Crohn's. It's just the effects are just quite incredible. Well, one thing that came to my mind there, Robert, very often I remember, as soon as patients used to get viral infections, the doctors would come along and say, ooh, you might get secondary bacterial infection, and they write them up for Magnipen or whatever the broad spectrum antibiotic was at that time. I'm assuming antibiotic therapy is going to disrupt the gut microbiome and potentially have significant adverse effects on our ability to generate innate mucosal immunity.
Yeah, it's a very good question. And I mean, this is one of the problems that you have with the fecal microbiome transplants, that you don't want to be using antibiotics at the time because you don't want to destroy the good bacteria that you've just put in. I had a patient a couple of weeks ago, which was a huge dilemma because it was one of the rare ones that was working slowly, and we didn't want to slow that down. But everyone said, well, maybe there's still some C. difficile. We'll give them some oral vancomycin, which is the antibiotic which is traditionally used, but not nearly as effective as FMT. So we had to tread very carefully we didn't want to destroy what the patient had probably paid a fair amount of money for and gone through quite a procedure. It's not a difficult procedure, really.
No, not at all. And sometimes I think Tom also dries it out and uses it in capsules, doesn't it? So you get spores,
He's now
spores from the bacteria that go all the way through.
So you can swallow it. And that, I keep telling him it makes most sense because those capsules those bugs will stimulate the Peyer's patches on the way through. So you're actually combining, doing exactly what we were talking about before, stimulating the immunity and replacing the bad bacteria at the same time.
And if they're enteric coated, that means that coating can take it through the acidity of the stomach to the alkalinity of the small bowel.
Exactly.
And just be released at that particular point.
Exactly.
Yeah. And I think Tom's, I'm not sure, he's only got about a dozen or 20 fecal donors. They're very carefully screened.
Oh, very much.
They're obviously, checked for all the basic, potentially infectious diseases, and it's a very safe treatment.
Tom's been approached by blood banks saying, well, maybe we should start establishing fecal banks, where you use that incredible stringent assessment of donors and specimens, just as you would with blood, you do with the fecal specimens. But we certainly test for all the resistant bacteria that you don't want to get, and all the nasty things that you can possibly get are all tested in every donor regularly.
Yeah. And part of the reason that some people are particularly healthy, they've got an optimum weight, they've got good metabolic health, they've got good immune health, is because of this great microbiome. And all they've got to do is give us some of the feces, and they can share that with the world. It's a wonderful thing to do.
Yeah. I think we're at the edges of all of this. It's very exciting, and we haven't even touched on the metabolic changes, metabolic syndrome, diabetes, a lot of the cerebral issues of change. And in the animal systems, by changing the FMT of a mother, you can actually influence the neural development of the baby mouse or rat, depending on what you're looking at. And of course, genetics are getting their ugly head in all of this. Who knows where it's all going to go.
Yeah.
I'd love to be 22 or 23 now, having to look at what I'd do for a PhD. It's just going to be so exciting.
Yeah. No, it really is quite...
Change the medical world. And when I look at what we're doing, I get tired of going to gastroenterological meetings because I still see people with inflammatory bowel disease. And every second, 2 out of 3, will be yet another monoclonal antibody that a big company's making its billions of dollars out of. And all they're doing, it's just like a sophisticated steroid. You're suppressing an inflammation rather than changing the basic nature of the disease. So we're starting to get to tin tacks at what is causing inflammatory bowel disease, systemic inflammation, chronic fatigue syndromes. All of these things now are getting back to this microbiome, which many people now consider as the new organ.
Yep. They're giving intravenous morphine. They're giving all sorts of sophisticated painkillers. They're putting local anaesthetics in the finger when all you need to do is pull the splinter out to get rid of the pain. It's just so basic and absolutely fundamental.
There's no
money.
I
know. There's no money in pulling splinters out. I know. I don't think I've ever got paid for one yet. Having done several thousand, probably more than that. So we've got this new idea that's developing. I like it. We've got things like the gut-lung axis or the gut-brain axis. The gut and potentially other mucosas, even potentially genital mucosas, are affecting the health of the overall other systems in the body which we didn't know were linked in the past, but now do appear to be linked through this what we can only call living in a natural ecosystem. We are designed, we've evolved for all this time with these natural ecosystems, and the idea that you can somehow ignore that is arrogant, really, because in my early studies, bacteria were always seen as the enemy, the bad guys.
That's right. If you go right back to the beginnings, back in 1900, when bacteria were first identified, only 20 years earlier, and people said, well, look, we've got this gut, we've got good bacteria and bad bacteria. And it was out of that concept that probiotics came. Yeah. And the first probiotic was in 1917 by a very smart German doctor called, and I don't know how to pronounce Nissle, but Nissle. And that E. coli that he found was a good bug, this particular E. coli, and he was using it to treat people with inflammatory bowel disease, is still available in the chemist shops today. I think it's called Mutaflor. And it's still, and studies have recently been done to show that it really does have a benefit in inflammatory bowel disease.
So over 100 years later, the pharma companies...
That's 110 years nearly.
Yeah, and the pharma companies don't seem to have read that literature yet. So
no. It's very cheap.
But this video, I'm sure, will put all the pharmaceutical industry executives straight onto it because they want to optimise the health of all human beings.
The funny thing, John, is when they get sick, they're very happy to have it.
Yeah. If you've got some personal interest in the game, the Americans would say some skin in the game.
That's right.
The spirit is enlivened.
Yeah, you mentioned the gut lung axis. I don't like to use that term. I used to, but now I'm thinking of this common system. I'm happy to see the gut brain axis because I think here you're looking at a mucosal system involving immunity and the bugs, but it's influencing the rest of the body. It's influencing the brain, it's influencing the bloodstream, level of inflammation. We know that relates to coronary artery disease, cancer. All of these things now are starting to be looked at in terms of how can they be influenced well or badly by the microbiome. And the database is quite impressive.
Yeah, no, the concept of a common mucosal system, I agree. I think that's the optimum concept that we need to work on, and the mucus immune microbiome protection system needs to be optimized.
Maybe it's called the common mucosal system, and leave out the bugs and leave out the immunity.
Yeah. So, I think maybe one of my takeaway messages here, Robert, is the idea that we want to optimize systemic immunity. Of course, we want the vitamin D, we want good nutrition. All of those things, but now we need to optimize mucosal immunity as well, and have a high awareness of both of these systems and the importance of both of these systems.
Yeah, I really think that's going to be a huge thing over the next X years, and we've started with a single bug that is highly protective in the airways. We can see how that can be extended with more powerful bugs to influence the gut. And I think that what we're going to be doing, and I can nearly promise you, but I probably won't be around when it happens, but that people are going to select out a bug that they want to stimulate immunity to that will change diabetes, change the metabolic syndrome, change fuzzy brains and things, chronic fatigue syndrome. We know all these things are occurring in those other systemic conditions, and it's just logical that this will happen.
Yeah, we just need to learn these specific bacterial microbiological interventions. And at the moment, we know nothing about the human virome. I mean, there's viruses in there, in the gut as well. Know virtually nothing about that. And we indeed the fungome as well.
10 times bigger than the bacterial microbiome. There are 10 times as many. Well, mind you, they're much smaller too.
Yeah. But they're obviously ecosystems, whether they're outside or inside us, are there for a reason. It's more learning to come there. And this ties in beautifully in my mind with Professor Dalgleish, Angus Dalglish's work, where he's actually injecting some attenuated heat-killed bacteria.
Yeah, no, absolutely. What Gus is doing is taking... he's worked on this for many years, and he's worked out a particular... it's basically a TB lookalike bug, and a product from that it works a bit differently. What I'm talking about when we were talking earlier about the T cells being stimulated is highly specific. What Gus is talking about is non-specific. He's stimulating all the T cells, and a number of those will go and be active in a cancer substrate. I don't want to complicate things, but whenever we get a specific response, we get a little bit of non-specific response. And Gus and I were talking about how we can start looking at screening different bugs that can have just the right amount of specific, the right amount of non-specific, ones that are creating the type of T-cell outcome that we want, because different diseases are demanding different patterns of immune responses.
And strangely, the regulatory authorities for medicines in my country have refused to license that bacterial preparation that he's
That's really
developed.
Strange, isn't it? Really strange. Particularly
very strange.
Maybe you should just call it messenger RNA, and then you don't even have to do preclinical work.
Yeah, I mean, it's almost as if that they want to promote sophisticated, expensive treatments as opposed to treatments that work. But of course,
look, I mean, can I just
possibly know that?
You and I off air were talking a bit about messenger RNA and the fact we're talking about factories and developing. I mean, I wished I could get some of the funds that's going in to messenger RNA factories. There's a remarkable woman in Australia who has chronicled all the money and where the money's come from and who's getting it. In pretty much all the universities are getting multiple millions of dollars to create factories of messenger RNA. Something that is not needed for vaccines. They're never going to be better. They'll be maybe sometimes as good, but they bring huge, unsorted out adverse events, and yet it's sexy, it's patented, and you can charge billions of dollars for and you can create a new vaccine a year. I mean, the latest is RSV. I hope I'm around long enough to have a proper assessment of the great value of that. I see that Pfizer's flu vaccine failed this week, thank God, because the thought of having messenger RNA vaccines for flu is simply frightening. And yet
the RSV RNA has been, the respiratory syncytial virus vaccine has been approved in the United States and Europe already, so it will be rolled out this
But it's crazy. Autumn. I wonder if they've ever read the history of vaccination in RSV.
I strongly suspect not.
Yeah.
Professor, as always, I get two emotions with these videos. One is completely fascinating, absolutely amazing. How sophisticated it is, and yet these are completely natural, designed, evolved systems. It's just so beautiful and so simple. And the other emotion I get is just absolute outrage that humanity is denied these wonderful treatments that our cleverest doctors have invented for us, but the riffraff like you and me in this case aren't allowed them because the regulators don't approve them. It's just
no, it's not a question. The regulators will improve it.
Right.
It's just that
Well, Gus's they didn't approve. They haven't approved that one.
The relatively small amount of money to put it through. We've got the whole thing done. It's not, well, knowing the regulators, I've got to be careful. I've got to be nice to them, haven't I?
Yeah, we have to be nice. Gus's bacterial preparation that he used, they won't license it, because if it was licensed, doctors could prescribe it compassionately.
That's right. Can't they can't only Gus is the only person who can use it, is he?
I think it's only in the context of, you'd have to ask Gus about that. I think he's used it in the context of trials.
Yeah, I mean,
it's not made available in BNF, because it was in BNF. Then people could just prescribe it compassionately, and
because it's got quite impressive database.
No, I would have it straight away. Why wouldn't you want to reduce your chances of infection, boost your immune system, and reduce your chances of probably most common cancers? Yeah. Probably.
Well, when he was out here, we had a delightful dinner, and we were talking about the various other things we could use that same sort of product for.
Yeah,
not just cancer.
Yeah, for sure. Right, let's hope someone's listening. But for the people that have listened all the way through, well done. Thank you very much, and thank you, Professor Clancy, as always.
A great pleasure, John. Thank you for having me.
Great to talk. Yeah, thank you.